And again, the reason why you have to listen to me for 45 minutes is that you're going to hear me talk about endocrinology and about surgery for pituitary, which I think that, you know, the thing that I've kind of adopted over the course of my career, what I've learned, is that you have to have a minor in endocrinology if you're going to do pituitary surgery, so I think it would be a good opportunity to convince you of that. So. Here's a quick little outline. First, I'm going to talk a little bit about pituitary adenomas and things that arise in the pituitary cella, the types of lesions that will arise there, some of the preoperative workup and perioperative workup that is involved in working on patients with pituitary tumors, which can be, quite complex. A little bit of the history of the approach. I was a history major in college, so you got to listen to that for a little bit. And it's kind of interesting in understanding the advances that we've made, and it's pretty cool over the last 100 some odd years what we're able to do now. Talk a little bit about the postoperative care, and then a little bit about, let me wax poetic for a moment about what I think minimally invasive surgery is. So, quick background on pituitary tumors. I think the title is actually pretty good. It's saying it's not in your head, because the first thing that people usually say to me when they come into the clinic with a pituitary tumor, which by the way I see at least 5 to 6 people a week with them, is that they think they have a brain tumor, and I usually correct them that they have an outside the brain tumor. Sometimes it's inside the brain, but not very often. So the most common things that we see are pituitary adenomas and Rathke's cleft cyst, which I'll discuss in a bit. Less common things, but what makes it interesting and always we have to keep a lookout for are these less common but imitators of pituitary tumors or pituitary lesions. Inflammatory lesions, hypophysitis, which can be pretty dangerous actually, aneurysms, granulomas, meningiomas, metastases, we've seen there, gliomas, and you see, once you're kind of building a pituitary practice, you just end up seeing a lot of this kind of stuff, so you have to always be thinking about it. Pituitary gland is a really important thing. And the thing that keeps it interesting from an endocrinological standpoint is it has this small 1 by 1 centimeter gland has all of these very important far-reaching effects throughout the body. So in the anterior pituitary, you have all these hormones like ACTH, GH, melano-stimulating hormone, TSH, as well as gonadotropins that control far-reaching things from stress hormone in the adrenal cortex, releasing cortisol to bone and muscle growth, to how the thyroid works. Obviously, the luteal cycle is very important from gonadotropins, which are made in the anterior pituitary gland. The posterior pituitary gland is really important for salt homeostasis, water homeostasis, as well as oxytocin for production and delivery of breast milk. So a lot of far-reaching things, which makes it really interesting from a kind of diagnostic standpoint. So the first thing I'll tell you about pituitary adenomas, and I was really shocked to hear this when I first learned about them, about 1 in 5 people, 1 in 6 people will have them. So they're very common. And again, most people that come in the clinic and have been diagnosed with them are freaking out because they think they have a brain tumor. And that means that about 1 in 5, if we do consider it a brain tumor, that means about 1 in 5, 1 in 6 people have a brain tumor, which is not really the case. So the first thing is just kind of talking people down and realizing like, hey, this is a common thing. And now, I know we probably have some neurologists in the crowd, but if you look at the neurologists like sideways, they're going to order an MRI for you. So we find a lot of these things, and which is great, which just keeps neurosurgeons employed as well. So that's part of the homeostasis. But yeah, so the overwhelming majority of these are going to be incidental and completely unrelated to the symptoms that people present with. And then when they are symptomatic, they can cause endocrinopathy. A lot of the times, hypersecretion syndrome, so pituitary gland not working as well as it should. And then more rarely, but in interesting cases that I'll describe, there's hypersecretion syndromes. And then another common reason why we operate on all these is that the optic nerves sit right above the pituitary gland, which we'll show in a little bit. And people can get visual disturbances, typically a bitemporal hemianopsia related to this, and more rarely cranial neuropathies. So the overwhelming majority of cases that I see in clinic are these, which are like which are these like very, very small, you can see right here, this little bit of hypointensity within the pituitary gland, which is right here. Here's the optic nerve, here's the brainstem, here's the sphenoid sinus, here's the brain, right? And so this little thing, maybe this one's like maybe 6, 7, 8 millimeters, something like that. So the overwhelming majority I'll see like that, but most people think they have something like this, where they've got a big tumor in the pituitary region, like causing hydrocephalus. Obviously, like this is more of a surgical case, whereas this one is something that we're going to watch for a bit. Types of adenomas. So there's a bunch of different cells, as I told you about, within the pituitary gland that secrete these hormones, and basically any nest of these, the way the pituitary gland is made is there's a bunch of these nests of these populations that make those hormones, right? And so any one of those nests can start growing in an abnormal way and make an adenoma. And the overwhelming majority of them are clinically non-functioning, meaning they're not going to be secreting high levels of hormone throughout the body. And then of those ones that are functional adenomas, or we say, or secreting adenomas, the overwhelming majority of them are prolactinomas, or lactotrophs. So a little bit about prolactinomas, because this is a common one we see, especially in young women trying to become pregnant. It causes amenorrhea. It can cause galactorrhea if the prolactin level is high enough. In men, we'll see decreased libido, feeling like their testosterone is off, basically. And there's a large differential of hyperprolactinemia, and this is something that we're working up all the time in clinic with the endocrinologist. There's this whole list of things that can cause the prolactin level to be elevated. So trying to understand that, a slight elevation in prolactin might not necessarily be associated with the adenoma, which again, as I'll remind you, is about 1 in 5, 1 in 6 people. So kind of sussing through that and looking at medications is an important thing. And the good news about prolactinomas is that we have very good medication for them. There's a medication that you can take twice a week called cabergoline, which is a dopamine agonist, which will make your prolactin level go down no matter what. So even if your prolactin level is elevated from any of these etiologies or an adenoma, it will make your prolactin level go down, and a lot of the time we're able to get people to become pregnant or have a cessation of their libido symptoms and all those types of things. I've seen some pretty amazing changes in young men being depressed and having a lot of problems, and then we put them on cabergoline and they're back to being young and vibrant again. So that can be a pretty a powerful thing, and that's something that we do with the endocrinologist. And it's interestingly enough, in other countries now, especially in Europe, where they care more about healthcare costs, cabergoline can be pretty expensive, and so they've actually kind of gone back to doing surgery for these. And so we're not really quite that way in the United States, and I think that my first preference for prolactinomas is to initiate cabergoline, but I'll show a case a little bit later on where we got a very effective response with surgery. So, acromegaly. Now, these are some of the really cool diagnoses that are just amazing of what a little tumor in the pituitary gland can do. This is hypersecretion syndrome for growth hormone, and we diagnose it with blood testing. And this has far-reaching problems. I mean, everybody's seen this kind of Andre the Giant kind of look, and that happens with high growth hormone levels. And it can cause a lot of different problems, sleep apnea, colon cancer, cardiomyopathy. So you can see how by taking out a tumor in somebody like this, you can really have a great effect on their life, which takes me to my favorite thing to treat, which is Cushing's disease. It's very rare, about 1 in 1 million. We've actually done a couple here already, so this is, I guess this is rare. We're lucky, but this is a hypersecretion of ACTH, and this has just an amazing effect on human beings. They will have, the story is pretty sad in most cases because it's insidious and it comes on very slowly over time. And the average time to diagnosis for a Cushing's tumor is anywhere from 7 to 9 years. So people go years of just feeling not very good at all. They're gaining weight, their bones are getting brittle, they're getting psychological problems, hypercoagulability, the hypermetabolic syndrome, diabetes, And all of it can be from like a 1 centimeter little tumor that we can take out. It's pretty amazing. Rathke's cleft cyst, this is another thing we see very commonly in clinic. The reason why these develop is that as the pituitary gland is forming, it's interestingly between involution of the mesoderm and neuroectoderm, and the posterior part of the gland comes from the brain and is from the neuroectoderm, and the mesoderm comes from the same set of cells that's making the sphenoid sinus. And basically you get this like residual little pocket of fluid, and that can be a Rathke's cleft cyst, and they're very common, maybe even more common than pituitary adenomas, often look like them. But in some rare cases they can get big and cause pituitary insufficiency and bitemporal hemianopsias. An interesting thing is a lot of people that have MRIs have headaches, and so we are trying to figure out whether or not their headache is from their pituitary adenoma or their Rathke's cleft cyst. In most cases, they're not associated. Unfortunately, taking these things out does not make people's headaches better in a reproducible way. Otherwise, I'd be a lot busier with pituitaries. So again, most Rathke's cleft cysts look something like this, asymptomatic. But in some rare cases, they can be big like this and cause compression of the optic chiasm, and we take them out or drain them rather in order to help with visual disturbance. This is another thing that's important to discuss, this idea of apoplexy, and this is a hemorrhagic or ischemic conversion of a cellular lesion, usually an adenoma or a Rathke's cleft cyst. And I actually see this not uncommonly. You always have to be thinking about it because it can be a life-threatening event. The reason why it can be life-threatening is usually from an endocrinopathy. And the thing that's life-threatening is hypercortisolemia. Basically, the patient loses their ability to stimulate their adrenal cortex to make cortisol, and they can have hypotension and die from that. So this is a really important thing to identify. Also, people can get severe hyponatremia or hypernatremia from pituitary injury, so you got to be thinking about it. And in this last year alone, I've diagnosed this a couple of times in clinic. Somebody came in and they just looked absolutely like death warmed over, and they've even seen endocrinologists and things, and people kind of missed that they're developing apoplexy, and lo and behold, their MRI shows some hemorrhage or some infarction within a pituitary tumor, and those are people that we need to get into the hospital right away to start hydrocortisone. And that can be just that initiation of steroid can be a life-saving event for these people. The other thing that they'll find is vision loss, and sometimes the rare urgent neurosurgical intervention for a pituitary tumor might be for apoplexy. So if somebody develops like acute onset blindness from a rapid expansion of the pituitary tumor, that'd be a reason to take them to the operating room. The other thing too that we see with apoplexy is cranial nerve injuries. So this is a third nerve palsy. So that's just another something to kind of look out for. So I've talked a little bit about the preoperative workup. It's really important that every single person that has a pituitary tumor receives these labs that we work up, again, just to check the entire pituitary axis and make sure that everything's working. And again, I am not an expert in endocrinology. I have a minor in it. And a lot of the time I can just see the things that I need to see to be able to send them to the smarter endocrinologist who can figure out exactly what dosage of these medications they need to be on and whether or not they need anything. There's a very protracted way of kind of going through this. I won't go through it, but there's consortiums from endocrinologists and neurosurgeons of how, because these are such common things, how do we work these patients up? How do we decide who goes to surgery, who doesn't? And so that's really good. Another thing that's really important is understanding the anatomy of the pituitary gland and the optic apparatus. This is a normal MRI of the pituitary. It's a T2 coronal. So what we're seeing here is the brain up here. That in this sequence, the spinal fluid is bright, T2 bright, and you can see the pituitary gland sitting here like this with the pituitary stalk, which connects right back to the optic chiasm. And if we move more anteriorly, you'd have the right optic nerve and left optic nerve. But you can see how this close proximity sets it up to be able to cause vision loss. By the way, here's the carotid arteries, which are our goalposts on either side there. And so if you get a tumor like this, you can see how very easily you could cause visual compromise. And because of the way that the fibers cross at the optic chiasm, the classic vision loss pattern that we'll see with a pituitary macroadenoma causing vision loss is this bitemporal hemianopsia, which is basically horse blinders. People being able to see their nasal fields but not their outside. It's very rare that we see a full, like, classic bitemporal hemianopsia. Usually it becomes asymmetric, but that's the reason why it's really important to have all of these patients where you're worried about. And basically my kind of thing that I do is if it's even close to the optic chiasm, usually I want to get some visual fields to make sure that we're not having an effect, because it's pretty amazing. Like in some people where you'll swear that they don't have visual compromise secondary to a pituitary tumor, it's just touching it, a little bit, they'll have it, and in some patients where it's deformed out of the way, they won't have it. And basically the presence of a vision loss is a lot of the time what we're using to decide whether or not to move forward with surgery. This is just to show this relatively new technology, maybe 10 to 15 years we've been using it. Optical coherence tomography, where a picture is taken in the back of the eye, and we're actually able to see the retinal ganglion cell layer in the back of the eye, and you can actually measure it with even better exactitude than a visual field optic nerve compromise. So this has been actually where I trained in residency. We had a very good neuro-ophthalmology program, and we were very early adopters of this OCT, or optical coherence tomography. And what we found is even if the visual fields were not off, OCT would sometimes show optic nerve compression that corrected after you did surgery. So nowadays, I really push ophthalmologists to get OCTs on anybody that I'm worried about visual field compromise, because if the visual fields are not off and there's optic nerve compression, there can still be some optic nerve injury happening. So that's a reason to maybe proceed with surgery more aggressively. All right, so now I'm going to talk a little bit about history. I won't make it too long, but this is really interesting stuff to me. So anterior cranial-based surgery and a lot of skull-based surgery really began with pituitary tumors, because as you might imagine, like, we didn't have MRIs in the late 1800s, but we were able to take a look at people and see whether or not they had acromegaly or Cushing's disease. And so that was the reason why it was an easier way to kind of make that diagnosis and figure out what was going on and decide whether or not people needed surgery. So Sir Victor Horsley, which is a really famous neurosurgeon, he invented bone wax, which we still use in the operating room, which is kind of amazing to me. And pretty much every time we do a craniotomy, I'm using it. And he started studying the pituitary by removing it in dogs, and he developed this subtemporal approach, which was kind of popular for taking out pituitary tumors originally. And he operated on the first pituitary tumor in 1889, which is pretty amazing. Apparently you had to have a really bushy mustache in order to be a good neurosurgeon. So unfortunately I wouldn't have blasted down there at that time. Good thing I'm here in 2025. Fedor Krauss learned from Victor Horsley, and he operated on his first pituitary tumor in 1905. And he did a better job of kind of publishing techniques, and I'll show the kind of a little bit of nuance on the approach that he used. So this is pretty brutal stuff. This is actually what Horsley did in order to take out a pituitary tumor. Here's the optic chiasm back here. He would perform a craniotomy and go underneath the temporal lobe using this like medieval-like stuff in order to take out the pituitary tumor. And that is the definition of a long reach. But he was described as really an excellent surgeon. All joking aside, I don't think that with all the gadgets that we have now for hemostasis and everything like that, it's amazing what these guys were able to do with the rudimentary tools that they had. So he would perform the craniotomy and then wait, and maybe a couple of days, let the person recover, make sure they didn't have anemia, and then go back and take out the pituitary tumor maybe a week later or something like that. This is an interesting thing where, as neurosurgeons and as surgeons in general, we're always looking for, we're always reapplying things that we're learning from other pathologies. And so Fedor Krauss actually was one of the first people to use fluoroscopy, and he was able to identify, and this is a reproduction of one of the first images that he took with X-ray in order to diagnose a bullet that had lodged right by the pituitary gland, which is going to be sitting right here, in the clinoid region, and somebody was injured with it. And he performed and described this frontal craniotomy in order to get to it. And then he said, well, hey, I saw the pituitary gland when I was there. That might be a better way of getting to pituitary tumors. And lo and behold, that became the kind of go-to surgical technique to take out pituitary tumors for many years. So you always got to be thinking, like when you're treating other pathologies, using what you're learning in order to treat other pathologies. So the first transsphenoidal surgeries that I'll describe in a bit were actually done by ENT. So Hermann Schlaffer is credited as doing the first transsphenoidal resection of a pituitary tumor. This person didn't do very well. They died 2 months after the resection. But both Schlaffer and Eiselberg kind of developed this technique, which looks kind of nuts. They would make this incision like this on the face in order to just translate the nose out of the way to be able to go through the nasal cavity and go to the pituitary gland to take it out. So a little bit different than we do now. This transsphenoidal route was adopted by the father of American neurosurgery, Harvey Cushing. You can't have a neurosurgery talk without talking about Cushing. And he performed the first extracranial resection of his first extracranial resection of a pituitary tumor in 1909 in a patient with acromegaly. And this patient did very well. He lived 21 years after that operation, which is, again, pretty amazing for 1909. And he, instead of like chopping the nose off and moving it to the side, he perfected this. Another thing that he helped develop is nasal speculum, which is a really important advance in order to transmit light down to where the pituitary gland is. And that was a major thing, as we'll see a little bit later on. It's just getting light down there to be able to see what's going on. It's something we kind of take for granted now. It also protected the nasal passages and gave a rigid retraction so you're able to safely take these tumors out. Despite all this kind of early work on the transsphenoidal approach in the early 1900s, it kind of fell out of favor. The reason why is you're going from a dirty place into a clean place, and they didn't have antibiotics, right? And so a lot of people were having initial, they would do well after the surgery. It's a nice approach. You're going right to the pituitary gland and getting right into the tumor. There's not too much bleeding, but then they would get meningitis and die. So that's obviously not a good thing. So Cushing, Walter Dandy, a lot of neurosurgeons around Cushing's time actually stopped doing the transsphenoidal approach and elected to perform a transcranial approach instead. And that became kind of the workhorse for a few years. But you can see that, and this is a young kid who I think had a craniopharyngioma from Cushing series. He did a really good job of documenting all of his patients, taking pictures of them. And you can see this kind of crazy incision that they would make in order to move the skin out of the way to get to the front of the subfrontal region. But thankfully, the transsphenoidal approach didn't go away. A Scottish gentleman by the name of Norman Dodd was a student of Harvey Cushing and kept on working on this technique. He added lights to a speculum, and he was able to do 120 transsphenoidal approaches during his career without any mortality. It was amazing. Gerard Guillot learned from Dot, and he used fluoroscopy to identify where the pituitary was, so it would make the surgery much safer from a navigation kind of standpoint. And he's from France. And then he trained Jules Hardy, who ended up in Montreal, and these two guys together. And Hardy really made it popular in the last century. So perfected instruments, perfected the speculum, started using an operative microscope, which is a way to transmit light down to where the pathology is. And that's really how we preserve the transsphenoidal technique. Where does endoscopy come in? Well, the interesting story there is actually from way earlier in the 1700s. And again, a 32-year-old gentleman named Philippe Bozzini invented this Lichtleiter, which is the German word for light conduction. Again, hopefully nobody speaks German here. I think that's what it means. But it's pretty amazing. I mean, this guy, who later died at the age of 35 from typhus, I mean, just to give you an idea of, what they were dealing with. He was using candlelight and mirrors in order to transmit light down to the end of a source. So he's credited of developing this endoscope. And he kind of, he's really sad. I was talking about it the other day. He died at 35. He had like 3 kids. His wife died like 6 months later, and he kind of, from typhus, because he was trying to treat all these people in this town. And he was kind of forgotten for many years. But I mean, this gentleman has developed this technique that is now used for all types of surgery. I mean, urology, general surgery, gynecology, otolaryngology, and all coming from this idea of transmitting light to the end of the scope. So we really owe him a lot for his ingenuity. So just to give a little bit of context, this is what an open transsphenoidal looks like, in my opinion. You're kind of looking at a keyhole from the outside without any way to look in, right? And that's what Harvey Cushing was doing in the early 1900s. And then with the microscopic transsphenoidal approach, we are still like working way outside. So our light source and everything is outside, and we're looking in, but we get better light in there. So we're able to start to see some things inside the room through the keyhole, but as you can see, still pretty far away. And when I first started, we were still doing some microscopic transsphenoidals. And you can see, but you can't really see that well. And then endoscopic transsphenoidal, just like, it's like being in the room. And you can go inside the keyhole and see much more. And so what's the deal with transsphenoidal? I love Seinfeld, so sorry about that. So this is the subfrontal approach, which Cushing and Dandy and all these early 1900 neurosurgeons would do in order to get to the pituitary gland, which you want to get to in this spot. So this is kind of what you're looking at. This is a cadaveric dissection with a good subfrontal approach. So you can see, here's the optic nerve, here's the optic chiasm, there's the pituitary stalk right there. Here's the carotid artery, here's a carotid artery olfactory bulb. So, and then the brain is all behind us with big retractors holding it back. So you have to transgress all this normal anatomy to get extracranial. So you have to go intracranial to go extracranial, which never really makes a lot of sense. And this is what it might look like if there's a pituitary tumor there. So you can imagine it's kind of difficult to go take this thing out because you got like the optic nerve in the way, and that's kind of important. You don't want to make somebody blind. And you got to like work in these windows in order to take this thing out. Why would you do that when we can come in through the nose, not expose any brain, and see a giant pituitary tumor like this? Optic nerve is behind us, away from us. Carotid artery here as our goalpost, and we have a perfect way to take out this tumor. So I decided to write that spot down. And just again, this is a little dramatic. I mean, usually subfrontal approach doesn't look like this, but just indulge me. This is what a craniotomy can look like. Obviously a lot more exposure, a lot more blood loss, a lot more things in the way, like the brain, which is important, versus coming in through the nose, which is less important, but still important, and getting to the pituitary gland that way. So the whole concept in this minimally invasive approach is preserving and not exposing normal, important anatomy in order to take out the tumor. So a little bit about the anatomy. This is a rodent dissection, but you can see the general concept of going into the sphenoid sinus to get to the pituitary gland, which is right there. This is the frontal bone, this is the ethmoid, this is the sphenoid, which sits behind the ethmoid, and these little things that you'll see here. This is like looking into the nose. There's the sphenoid os. That's the place that we want to get to, which is kind of the keyhole to the sphenoid sinus. Where the back wall of the sphenoid sinus is where the pituitary gland sits. This is what the bony anatomy of the nose looks like. So we're going to move the inferior turbinate, middle turbinate out of the way to get to this little hole called the sphenoid os. This is what it looks like in vivo. So that 3 spot is the little hole we want to get into in order to open up the sphenoid sinus. And once we open up the sphenoid sinus, we're presented with this awesome view of the relevant anatomy for taking out a pituitary tumor. Once you take down all these septations, you're left with the carotid artery, the optic nerves up here, another carotid artery, here's the pituitary gland with cavernous sinus all around it, here's the anterior skull base. And we won't talk about it today, but we can take out a lot of different tumors in the anterior skull base through this kind of workhorse approach. So this is just one example of a kind of a nasty tumor that we took out with this approach. And you can see, I mean, this, I know the subtitle of the talk is "It's Not in Your Head." This one is definitely in your head, and is causing hydrocephalus, so a pretty big, nasty tumor in the third ventricle. And again, without transgressing the brain in a serious way, we're able to expose the pituitary gland here. And what you're looking at is the pituitary gland, which is now being opened up sharply. We're starting to take out some tumor and clearing the tumor out of the sella here. And you can see that through that spot, using angled scopes and such, and these special instruments, we're able to reach all the way up past the normal pituitary gland into the intracranial space and start taking tumor out of there. And again, this is all through, it's all looks zoomed in and everything, but this is through about a 2 centimeter exposure in the pituitary gland. So really not that bad. And you were looking into like the soul of this patient. This is a third ventricle. This is not a place that is usually seen. And so it's a really, it's just amazing access that we're able to get. We're getting all this tumor out through that small opening. There's a little bit of blood there, but as you can see in the postoperative imaging, you're able to get all the tumor out through that little small approach. Here's the septal flap, which is moving our tissue inside the nose in order to help repair that defect. So postoperative management, because the pituitary gland is important and has a lot of far-reaching consequences, I really depend upon our inpatient team here who's done a fantastic job in taking care of these patients, and I'll talk a little bit about that. So some of the basics for me is I keep the head of the bed up for 45 degrees for about a week after. We have to check sodium, make sure that their ins and outs are recorded well. This is not usually too painful of a surgery. We try to minimize opioids as much as we can in the post-operative period. People talk about straws. I'll talk about that in a moment. And the other thing too is everybody's scared about DI or diabetes insipidus, which I'll discuss in a bit, but it's actually pretty rare after these resections, these surgeries. These tumors, usually about a 10% rate or so. So the actually more common thing is people drinking too much and getting SIDH. So straws don't suck. So this is anybody who's worked in the inpatient neurosurgical side of things knows about the fact that you're never supposed to use straws after transsphenoidal surgery because it's going to precipitate a CSF leak. Well, the place where I did my fellowship, they actually studied this by putting pressure monitors in the sphenoid sinus and tested all these things. It's pretty amazing kind of work they did, but they found that there was no change in creating negative pressure in the sphenoid sinus if you use a straw. So I usually say, if you got a big thing on your nose is all clogged up, it's really hard to like drink out of a cup. So we tell people use straws as much as you want because they don't suck. Well, they do suck, but not in that way. SIDH is the most important thing, or the most common thing that we kind of see in the postoperative setting. About 20% of patients, and it's the most common cause of readmission after transsphenoidal pituitary surgery. And so if their sodium is relatively normal postoperatively, I usually put patients on a fluid restriction that we'll do for at least a week and check some post-op labs. Diabetes insipidus is one of the more dangerous things that can happen after surgery. Again, thankfully it only happens about 5 to 10% of the time. And diagnosing it can be difficult because folks get a lot of fluids during surgery, and it can cause some confusion when they're mobilizing that fluid. But we have all of these different ways to qualify whether or not somebody has DI. And we've got some really good ways to treat it. Again, most of the time it's transient, and the overwhelming majority of folks will not need to be on long-term supplementation for DI. But if they do, it's actually something that's treatable. There's this nasal spray which works really well. You just have to do 1 puff a night, usually maybe twice a day, and that can work really well for folks with DI. That's usually my preference because the bioavailability is more standard if you do a nasal spray. If you're doing oral, it depends what you're eating, and everybody's a little bit different, so it's a little hard to titrate. We also check for cortisol levels post-operatively. We want to make sure that the cortisol levels greater than 7 post-operatively, and in most cases when they're not, we don't need to replace them. So there are a lot of centers that would put people on steroids post-operatively. I'm always yelling at the anesthesiologist to not give them any steroids, and most folks don't need any replacement there. These are some important things for secreting tumors. We want to make sure that we've gotten all the tumor out, because a cell left means that we wasted our time in the operating room. So we want to make sure that our AM cortisol after resection of a Cushing's tumor is very low, and then we replace it, and for growth hormone in cases of acromegaly. So just to finish out here, I wanted to talk a little bit about what minimally invasive cranial-based surgery is, because I've talked about all these like cool things with this approach, but it can be quite dangerous, right? You can have problems. You have morbidity with creation of these nasoseptal flap. You can kind of make really bad problems. I mean, neurosurgeons don't like to talk about the nose, but when you blow out somebody's nose to take out one of these tumors, you can really cause some problems. They can have some lifelong, like sleeping problems, breathing problems, air hunger problems, and so you got to be careful about that. The other thing too is you do have the carotid arteries in your way, and that can be a disastrous problem. We're working outside the nose, and if you get a hole in the carotid artery, that can be a life-threatening event. About 20 to 40% of the blood flow goes to the brain through the carotid arteries, and so or cardiac output goes into for the entire body goes through the carotid arteries. So that's a lot of blood happening really quickly. So that can be a life-threatening event. And then spinal fluid leak can cause meningitis, and people can have anterior pituitary dysfunction. So that's a big problem. So minimally invasive is one of these terms that's thrown around a lot nowadays. It's like, do you need a fancy robot to say you do minimally invasive surgery? Do you need all these little stab incisions and little tubes and spine surgery, which I do? Or is it using endoscope? And I say it's not any of those things. It's more of a mindset, and this is the group of people that I learned from when I was in my fellowship. I think that minimally invasive skull base is all about emphasizing, sinonasal outcomes and making sure that you're getting people in and out of their surgery safely and in and out of the hospital safely. Just do what you need to do in order to access the pathology and nothing more. Using the right instruments is really important, which St. Luke's was gracious enough to buy from me when I showed up here. I always want more, but they gave me enough. We also want to use evidence-based modifications to our technique and think about the reconstruction after resection of these tumors. So these are some of the instruments that I use in the operating room in order to make these surgeries as minimally invasive and safe as possible. The reason why I use these is that the gentleman that I learned from, Jim Evans, who I think is one of the best cranial neurosurgeons in the world, developed these, and they help us to be able to do these surgeries in a really safe way. And this is the final video I'll show of a patient with a prolactinoma who didn't want to use cabergoline, and this is what their little tumor looked like, and I think this shows how minimal access we can be and really offer patients a good outcome through very small incisions and leaving the hospital post-op day 1. So again, this is opening up this is one of my ENT colleagues opening up the sphenoid os. And again, you can see we're just doing very minimal exposure of things in order to get into this workhorse area. And we're using these small drills in order to drill out the pituitary gland. And here, this is different because this tumor is very small, so the bone hasn't remodeled in this area. But again, the area that we're working here is about a 1.5 by 2 centimeter little area. So if you see me kind of like not looking super precise, that's the reason why it's zoomed in. So just give me a little bit of a break there. But this is what we look like when we drill everything out. And again, we can use these little knives in order to open up the pituitary gland. And what we're going to do is just really take our time and dissect in this plane, find where the normal pituitary gland is, use these really small instruments in order to, again, selectively find this, again, probably 5 to 8 millimeter total tumor within the pituitary gland. So again, we're just dissecting, and there's this nice little capsule around the tumor that we kind of take advantage of and tease it out. Again, over the course of not too long, probably about 30, 40 minutes is what this takes, and just teasing away the normal pituitary gland and finding this thing and dissecting it out. and not causing any holes in the cell, in the outside of the tumor. I think I caused a little hole at one point, which you might see, but again, just really taking our time, making sure we're not injuring the rest of the pituitary gland, which is sitting over here, teasing this thing out. And you can see with this very small approach, we can take out this microadenoma and get the whole thing out. And of course, you got to measure it, so we do that. And then kind of just clean things up. And again, the area we're working in here is about centimeter max, and close everything up. This patient went home on post-op day 1, and their prolactin level went down to a normal level. So another reason why maybe we should be thinking about minimally invasive surgery for some lesions like that. So minimally invasive cranial-based surgery is a mindset where surgeons avoid morbidity by tailoring our operative techniques and specific strategies to patient traits and pathology. So I also have to thank Dr. Chaffin, who is the ENT surgeon I work with. He does a fantastic job in setting these cases all up for me. We work together in order to emphasize our sinonasal outcomes. Chad Jackson's oculoplastics a surgeon who, again, eye pathology is very close to pituitary things, and we, in fact, just earlier this week, we took out a meningioma from somebody's orbit through a endoscopic endonasal technique. Of course, I'm very dependent upon our fantastic endocrinologists within the St. Luke's Clinic who help me work up these patients and then deal with the fallout when they have some pituitary dysfunction post-operatively. And thank you very much for your time. And I'm sorry again what's going to happen tomorrow.